Well, I will welcome everyone. Hello and welcome. We're very happy to have Catherine Drabiak. I hope I said that correctly. Here with us. She's an associate professor at the University of South Florida College of Public Health and College of Medicine. She's also the co-director in the Law Medicine Scholarly Concentration Program at USF Morsani College of Medicine. Catherine's teaching and research is focused in law health, public health, and medical ethics. She's authored numerous law review articles. She's got experience consulting in both research ethics and clinical ethics to develop guidance policies and best practices. She's a member at Advent Health's Medical Ethics Committee, and we are very pleased to have her here. So I'm going to turn the floor over to you, and please put your questions in the chat box, and we'll have some time at the end to address them. Thank you.
Thank you so much for that introduction, Rachel, and thank you, Dr. Bazelak, for inviting me. I really appreciate it. So my general area is health law, as Rachel mentioned, and this topic was one case that kind of happened across our desks in the Advent Health Medical Ethics Committee. And it was something that we had encountered a couple of times before in our ethics service and didn't have a lot of information about. And so that's kind of where this project originated. So I'm going to today do a brief overview of what happened in this particular case. I'm going to shift to some situations where you and your colleagues might be encountering the prison population or other people who are incarcerated, and then really bridge this divide between what does the law say, what do medical ethics say, and then special considerations for incarcerated patients. So the first thing is, who is the prison population? First of all, it's quite large. So it's not only prisoners who are in the prison system that has their own method of healthcare, but also people who are incarcerated who may be coming into the hospital or coming into other clinics for services like surgery, for services after a violent assault, or things to manage their chronic disease. So the case that we had, this was the case of Mr. T. He had come into our facility after a violent assault, which happens pretty frequently with this population. So he was admitted into the ICU. He was unconscious at the time, so he was legally competent, but lacked decision-making capacity. He had extensive neurological damage. So there was also questions of, is he going to regain capacity or not? And when the clinical staff asked questions of who's the decision-making person, who's the appropriate person, and was trying to find out more about his family, the warden intervened at this point and said he was the decision maker. So this raised a number of different ethical and legal questions of, was he the legal decision maker? Could he assert that authority? And then what are some of the ethical questions that come up with that? So as I mentioned, people might encounter this population with emergency medicine, and sometimes this is not people who are already incarcerated. These are people suspected of crimes like knife or gunshot wounds, who also may be seeking pain management or support if they're kind of transition to an end-of-life patient, surgeons managing chronic conditions, and specialty care for managing chronic health needs. So the other thing about the prison population is that it's a very different population demographic based on age, race, socioeconomic status, and then most notably for this purpose, very different medical conditions. So people who are incarcerated have higher rates of hypertension, diabetes, mental illness, substance abuse, attempted suicide, cancer, traumatic brain injury. So the list goes on. This particular population has very discrete health needs. They also have higher rates of communicable disease. But for the purpose of palliative care physicians, some of these issues of physical assault and violence means that you may be experiencing people who come in who have, as with the case of Mr. T, extreme neurological injury or high pain based on whatever the assault was that they experienced. Some of the reporting shows figures at about 25% of prisoners are assaulted per year, but there's a lot of criticism of that number based on low reporting, prisoners not wanting to snitch or have adverse consequences based on reporting. I also want to point out that particular statistic excludes sexual assault, which would also have implications for pain management and managing other symptoms related to sexual assault. So the last component to talk about here relates to accelerated aging, which is a term that applies to this population because of all of these different health conditions, all of the stress that these people are in the carceral setting. It contributes to they age faster. So it's exactly what it sounds like, but also the fact that they die on average about 2 decades earlier. So why does this matter? Because many are unprepared in terms of end of life planning, of where they think, what age they think they would be when they would die, which means they don't have an advance directive or a living will in the same kind of percents as we would see the general population. They're also less likely to talk with their friends or family about these things because of their isolation in the carceral setting. And oftentimes they lose contact with friends or family over the years. So when that point hits where they're making those end of life care decisions, we often don't know what this population wants. So there was a Supreme Court case back in the 1970s, Estelle versus Gamble, that really established this bare minimum standard of what medical care is required for people who are incarcerated. And what the case said was that incarcerated patients have a right to receive necessary medical care. So this kind of harkens to the fact that when you as a physician are seeing the patient, that you are focused on what this particular patient needs based on their clinical symptoms at this specific moment in time, but not assessing what did they do before they came in to your examination room, what kind of person are they based on what crime they committed, or any of those other factors. This case also laid out a number of different provisions saying that physicians and other clinicians cannot intentionally refuse to provide medically necessary services or deny them prescribed medication, or kind of prevent them from getting the necessary health care that they need. There are a couple of exceptions and caveats to this. Based on if different decisions would impact the rest of the prison population. So the American Medical Association also jumps in on this and says emphatically that just because the patient is the prisoner, doesn't mean that they lose their legal decision making. So again, treating the patient as a patient, not as a prisoner. And we'll get into some of the catch-22 here of when you do need to treat the patient as a prisoner in a moment. So what does this mean for some of the ethical components? Well, again, upholding this tenet of informed consent. So making sure if we can't get the patient's informed consent, hear the prisoner, making sure that we get either the surrogate or our proxy's informed consent. And this upholds the principles of autonomy, bodily integrity, and respect for persons, just like any other instance of informed consent. So we always presume that the patient has capacity, and to kind of map this into the situation that we had experienced in Advent Health, it was clear that Mr. T, the patient, did not have capacity. So what the physician in this case was trying to do is implied consent in the emergency, right? Stabilizing the patient. And then after that, okay, it's clear he doesn't have capacity. So what do we do then? So this is kind of the framework to look at. Is there a surrogate that the patient in this case has actually designated? So hospitals or prison settings can do this in a couple of different ways of either having some type of intake paperwork or paperwork upon admission. And if there's not a designated person, then looking in the surrogacy hierarchy in the law. And then here's where it differs a little bit with the prison setting is the Department of Corrections for every state also has policies for how to deal with these types of situations. And one of the things that I've seen in a couple of other cases, not this case, was that in some instances, the warden thought, or other officials in the institution thought that the Department of Corrections policy somehow superseded or overrode what the state law was or what the prisoner slash patient said he wanted. And that's not the case. So the Department of Corrections policy is intended as kind of a supplement to whatever the state law says. So, for example, if Mr. T happened to have an adult mother or a wife, again, depending on the hierarchy and who was in his life, that's who we choose first. And these policies vary significantly depending on what state you're practicing in. So, to give an example, in some states, they say if there's no other family member available, the warden can serve as the patient's decision maker. But other states actually say the warden cannot serve as the decision maker. And this kind of goes to, well, who knows the patient best, right? Who can serve his needs versus potentially conflicting needs of the institution. So there was another interesting case that came up that I think is important. And again, this was just in one particular jurisdiction. So the lawyer ahead of me says this might not be binding on folks in other states, but it's just something to be aware of. This was a case of Cummings versus Davenport. So there was a man who was in the prison system, Marquette Cummings. He had a stab wound to his eye. He was admitted to the ICU, and his mother was trying to make medical decisions for him. She would have been the appropriate medical decision maker. The warden kind of jumps in and says, I'm making the decisions. I have custody over the prisoner. And so without even communicating with the mother, kind of overrides her and withdraws life-sustaining treatment from Marquette Cummings. So you can imagine kind of the ethical things going on here and these violations that Cummings' mother is feeling at this particular moment. And so there's a couple of legal takeaways as well. The court here said that the warden has to look at what does the state law say? Again, the warden's not the decision maker. In this case, it would have been the mother. And so this actually kind of created some liability for the warden and the corrections department in this particular case. So just something to be aware of if you're working with prisoners, again, to make sure that you're following kind of the chain of command of legally who's the correct decision maker. And to supplement, okay, what's the law? Well, why? Why is the law the way it is based on these ethics? So I've already mentioned respect for persons, and this gets to the idea that people who are prisoners still deserve the same level of care and attentiveness and treatment in their medical care as people who are not prisoners. This also closely relates to non-discrimination and justice, that there's different populations. Being able to trust clinicians. So this idea that that if the patient comes into you, that they're knowing that you're providing them the best medical care possible, again, based on clinical symptoms, based on what their medical needs are, and that their family sees this, if it's a family member making the decision. And also pointing out that prisoners are a vulnerable population in the law. And so they already face certain constraints with their bodily integrity, their autonomy, and that making medical decisions is not an additional constraint or taking away their ability to make medical decisions. So, on the flip side, I do want to point out that there are a couple of different ways where physicians would need to treat this population of patients a little bit differently. So, the first has to do with security concerns. So, even if, for example, to use the case of Mr. T or something similar, if there's a patient who comes in either after a serious assault or a patient who's coming in kind of related to treating cancer, oncology, and some of the pain management related to that, um, you'd still have to look at what is kind of the level of risk of this particular patient as a prisoner. So, this has to do with, are they going to use a surgical scalpel to try and attack the staff? Are they handcuffed? And some of this has to do with even patients in kind of dire clinical straits still attempt escape or violence, which places not only them at risk, at physical risk, but also the clinical staff. So there's certain things that kind of come into play here of how to manage communication with family, to keep the family apprised of the patient's status. But for some of the high risk or high flight risk patients, it may be doing this over the phone versus having the family come in, because the family presence could sometimes be a security risk in itself. The second thing to point out here has to do with isolation of this particular population. So, if prisoners are away from their family for long periods of time, they may have estrangement, limited visitation, limited communication, and this impacts their ability to communicate with their family about what their end of life needs are, how they want to manage certain conditions. And so it may be more difficult to understand, again, what are the patient's values and wishes versus what does this person think the patient's values and wishes are. So, in the literature, there's been a couple of alternatives proposed, and these are just things to kind of mull over and think about. So, there's quite a bit of opposition of should corrections staff kind of step into this role. Some people say yes, because, well, maybe they know the patient's needs and wishes. Some people say absolutely not, because they have competing interests. Um, and some people say, well, maybe we can, instead of family, if they're estranged, we can rely on prison friends. And this is my 2 cents, is do this cautiously, because in the carceral setting, there's a lot of, I would say, strategic alliances versus true friendships because of this kind of the physical constraints and the high levels of violence. So there's not a perfect answer, but just something to be thinking about. So, the takeaway points to really drive this home is that incarcerated patients don't lose the ability to make their own medical decisions, whether on their own or through that hierarchy of decision making if the patient is incapacitated. And if the patient doesn't have capacity, then it follows the normal procedure. And we can incorporate kind of what's going on in the Department of Corrections, but the warden or corrections staff cannot step in and kind of swipe all of that away. And this is important for upholding some of these ethical values and making sure that it's optimal patient care for all of our patients. Thank you for your time.
Thank you. That was very informative and really illuminating. I think a lot of us have encountered experiences with patients who are prisoners, and a lot of times we get a myriad of questions from the other providers we work with or the team. And so this has been very good information. We do have a couple questions in the chat. Let me bring them up.
Great.
So Jen asks, why can't families be more involved with their loved one's care, do they call next of kin when these situations happen? Since Cummings versus Davenport, have you seen changes in state policies?
So I'll answer the first one of calling families first. I'll answer that portion. I think it's important to get families involved. Again, just like any other situation of making sure that the family is involved, that the family knows what's going on with the patient. If the patient lacks capacity, in particular, one of the caveats here, as I mentioned, it depends on the type of the risk of the kind of the status of the prisoner. And so one of the, I would say, the best practices that I've seen here is also kind of doing this in a team with the Department of Corrections. And so they can kind of help work with how to communicate this to family and how involved families should be, because there's been a couple of cases where family gets the information and then they essentially come to the location of the hospital and help the prisoner break out and endanger other patients in the interim. And so there's still some hurdles there, but it's, I think, a good way to approach it is a team communication of how can we best communicate, and having that expertise from the Department of Corrections on how to do that. And then the second component, I think, was asking about Cummings versus Davenport. And I think there's, I would say, it's so complex that there's almost a confusion around it. As I mentioned, some of the cases that I was reading, and even there was a couple of cases that had come up, just medical ethics cases in our hospital. It was a question mark of, can the warden do that? And so I think there's just such complexity around this that health law professors or lawyers aren't doctors, doctors aren't lawyers in most cases. And so it's just a question mark of, can they do that? So I don't know if it's changed much, but that's exactly why I think it's fantastic that you all organize something like this to kind of bring attention and awareness to that.
Had a patient who was a prisoner, and the warden had informed the healthcare staff that the healthcare staff could not call the family, even though this patient was being put on end of life care. And this happened on a weekend when I wasn't here, so it sort of just happened. And then I got an update at the end, and they did call an ethics case in the hospital. They brought the whole team together. They reviewed the state information that said, yes, we should be informing the family. Whether or not the warden is saying yes or no, the family at least deserves to know what's happening with their loved one, I believe was the outcome to that particular thing. So it is, like you mentioned, most advised and the wisest approach to have that team approach.
Mm-hmm.
Yeah. I know Jerry mentioned that he's seen cases in Missouri post Cummings versus Davenport where prison officials still try to assume surrogacy decision making, is what he notes. And I know Marty had a question, so I want to open the floor up to him.
Yeah, thank you, Catherine. That was really wonderful. My question is kind of a big one. I don't think it's even fair to assume a complete answer. It's probably a lecture in itself. I'm just hoping you can share a pearl or two of wisdom about this. So you wear both a legal and an ethical hat. And so we were talking a little bit about this before the start. Do you have an approach or a framework or some sage wisdom about how you start to approach situations where what is legally right to do, what is ethically right to do are truly in conflict with each other? Anything you can offer, because maybe that's not a fair question, but I would appreciate some wisdom on that.
I think you're right that could be an entire lecture. So I'm trying to think how to answer that. The first I would say, and this is kind of a cheating answer, but the first I would say is to clarify exactly what the law says or doesn't say, and then move to the ethics of it. So here's what I mean by that. Oftentimes, I have emails from what I would say like exasperated other professors or exasperated students saying that they're furious about a particular bill or a particular law that's going on, oftentimes having to do with health or public health. And it turns out that with a lot of these issues, it's been what I would say kind of mishandled with the media or misrepresented. And so the first thing that I start to do is kind of parse out, what does the law actually say? And an example of this that is not on this particular topic, but that came up very recently, had to do with a law that we had in Florida. It was about physician reporting of immigration status of all patients who come into the hospital. And so it was blown way up in the media. People were very upset about it. So that was kind of the first component of what does the law actually require? Because some of what people were getting very upset about or angry about was not even in the law. So that's the first thing. And then the second thing is, okay, if the law requires something that you think is inappropriate or unethical, how can you do the best and kind of fulfill the tenets of your professionalism and your ethics while still complying with the law? So that's step two. And then minimizing whatever the ethical violation is. And then step three is if it's something I would say atrocious or terrible, and again, people would define that very differently, but raising awareness of it or seeking change and in a variety of different ways. So raising awareness with lectures and talks, raising awareness to the public, writing op-eds. That's something I do. If I get angry about something, I'll just write an op-ed. That's my way of getting it out. And then hopefully influencing people to change the law. So that's kind of the way that I approach it. It's a great question.
Thank you. Good. I didn't see any additional questions that come in. I'm going to sneak in a second one if you'd let me. I wonder, I just do not know if there is any impact on being incarcerated on capacity, because you highlighted the isolation that happens there. And we know that in some mental health, there's an impact on capacity because of how they are perceiving and weighing reality. Do you know, is there any literature out there, or is that something people are thinking about how just incarceration itself and the impact of that may or may not be impacting the capacity of the patients that we're seeing?
I haven't seen anything about that specifically, but I know that there are differences in rates of mental illness, differences in rates, as I mentioned, of physical assault, where somebody suffers a neurological injury, but also suicide. So this is something in suicide attempts. I think this would be something that, again, I don't have the answer, but it's an interesting question, again, of the isolation, kind of being able to make decisions. It ties in a lot of different ways of, first, being able to make a particular decision. Second, do they have friends or family supporting them if they can't make the decision? And then this gets to some of the bigger systemic issues that I don't think we have time to cover. But I think all of it goes back to when the patient reaches you, of treating them as you would any other patient with those particular symptoms.
Yeah, that's excellent. Really excellent. Well, thank you so much for your time. We're thankful that you were here, and hopefully you'll share your contact information if other people have other questions or would like some follow-up.
Yes, thank you so much.
All right, we hope everybody has a beautiful Friday. Enjoy that nice fall weather.